There we go. So, Nomai, Hadimai, everybody. Welcome to another In Conversation at the OT board. Today, I'm joined with Linda Robertson, who's Associate Professor down in Otago Polytechnic, down in Dunedin. And Linda is retiring after, well, how many years, Linda?
Well, 30 years here in Otago.
Yeah, 30 years here in Otago, but longer than that in the field of occupational therapy as a practitioner, I suppose. Yeah.
Yeah.
So will it be nearly 50 years?
Yes, it must be about that now. Yes. Yes. I haven't counted it all up.
No. Okay. So
Yeah.
when are you actually retiring, Linda?
Now, this is my
Yeah.
last day. They're trying to take everything off me today.
But you're hanging on to a few master's students that you're
Yes.
um, sort of
Yes.
supervising their dissertations. Is that right?
That's right.
Okay.
Yes.
All right, Linda. Well, thank you for joining us, and thank you for making the time as you leave Otago Poly probably for the last time.
Yeah.
Yeah. So going right back to the very beginning, we can start there. It's a good place to start. What first attracted you to occupational therapy?
Goodness, it's a while ago, but one or two things I recall that probably have some influence. One was I was working in a rest home as a nurse aide, as you do when you're a student before you get to the real world. So,
Yeah.
but it was I was impressed by some quite young people who had multiple sclerosis in the rest home, and they were just sitting there reading a book that was about as much as they did in the day, and that felt pretty depressing to me. So that was one thing. My mother was a psychiatric nurse, and when I was at high school, she went back to work. And she was a great advocate for doing Scottish country dancing. So we had Scottish country dancing right, left, and centre, including with the patients. And you could see the value of that kind of thing with people. They love being able to do something like that rather than whatever chores they were doing. She worked at Ashburn Hall up in it's a private, well, it's now a private place up in Dunedin. So there was that. And I must admit, it appealed to me to go to Auckland because I was from Dunedin. And in those days, you didn't do much travelling. You hadn't sort of. I had barely seen New Zealand. I think I'd been to Christchurch once at that point, but all my experience was very much bottom of the South Island. So this was potentially an exciting venture, I'd have to say. So yeah.
So that was the first training school, wasn't it, in Auckland?
Yes, it was at Oakley Hospital.
Yes.
So well and truly under the health board in those days. So I know we took in students every 6 months. We took in was with Francis Rutherford was
Yeah.
the principal.
Yeah.
So every 6 months there were students coming in about, I don't know, 15 or so. Wasn't huge numbers. And I ended up being in the second year of the program. We went down to Christchurch for the whole year actually. We had tutors come from America, and we got sent down to Christchurch as a group. There were only about 6 of us, I think, that
Yeah.
did that. So that was a bit different. And then we came back to Auckland, and so it went on. So yeah. So,
I hadn't realised that obviously the training school was set up by Francis Rutherford, but I suppose there weren't the lecturers or the OT lecturers around at the time to deliver to the program. Or was it very medically orientated? You got lectures from doctors.
it was a combination, especially in Christchurch. Actually, we had, as I said, we had 2 occupational therapists who came over. One was physical disability, I think. One was more mental health, if I remember rightly, both American. And they did our OT sort of orientation and supervision and that kind of thing. And then we did quite a lot of things with the other students, like with nursing students in particular. So psychiatry, for instance, was always with the nursing students. And unfortunately, the Auckland program set set the exam, and they had a very different orientation to mental health than we did. And quite a few of our group failed, myself included, the
Oh,
mental health aspect of it, because we were right into group therapy. That was a new thing.
yes.
And so the psychiatrist was very keen for everybody to run group therapy, and all students were included in that as well as staff. So it was a bit scary, I'd have to say. But anyway, so we did have lectures with them, and I think surgery, those sorts of things were all combined lectures with, God, I'm not sure who, to be honest. Sometimes it was a while ago.
Yeah.
Yeah.
So when you look back at that time and the training that you had, and when you look now at the education and preparation of OT students, they're really miles apart, aren't they?
They are. It's very different. We didn't have a lot of OT theory, OT specific classes. We had, they were very practical classes by and
Yeah.
large.
Yes.
But we didn't have the theoretical components. We didn't have the research components. We didn't have the literature on hand. None of that. So while we were learning new things constantly, I still remember doing a project on proprioceptive neuromuscular facilitation as something we had to prepare this to and present to the rest of the students in the third year. And I have a feeling we used mainly physio journals to get that kind of information from.
Right.
And there were some textbooks, McDonald's textbooks, one or two others that were useful, but there wasn't much of a library that I can recall. And in fact, I even recall when I was working in Palmerston North, and about third year out, there was somebody who was a physician. I had asked if we could put in a program for patients who with heart conditions, that kind of thing. I went into right panic because I didn't know where to go for information. We didn't have a library, and I'm not sure that I was orientated to even doing that kind of thing in the early days, believe it or not. So, so yeah, the resources and the accessibility to information has improved enormously, really.
Yeah. And when you look back over the last 50 years, what do you think are some of the sort of highlights for the profession?
For the profession was, I think the move from it just being a kind of I don't even know what I've got. I've got a piece of paper that tells me I can register. So that's about it. It became a diploma, of course, then it became a degree, and then we went into the postgraduate degrees and so forth. So there's been huge change in the profession. And so students have a very different experience than I would have had. And I think, I don't know, I think we worked a lot more interprofessionally actually when I started out. And we learned interprofessionally too. So, there was a lot of that was just convenient for the doctor or whoever was lecturing to do that. So we did a lot of that. I don't know, I mean, from my own sort of personal journey, it was like to get confidence that you were good enough to sort of compete without, or not compete, but say your piece in front of other people, and those sorts of things took about. So it was quite, those interprofessional sessions were good for that, from that point of view. And then eventually I did go to university, and I felt where I was surprised that I did as well as I did, to be honest. So that was good. That was a good learning experience. It's good to know where you stand in the world of academia. So that was the beginning of my move into an academic world, really, and move on to masters.
What was the degree you took when you went to the university? Was it?
Well, I started when my first degree was as a BA in sociology, and I did this when I was in America. I had traveled by that point. I'd been with volunteer service for a year, and then I had traveled for quite a bit of time. So I was keen to do something that wasn't occupational therapy, to be quite honest. So and I thought sociology seemed like a good thing, and in particular I looked at some of the things around older people and the issues that come up with that, so sociology related to that. And so, as I say, that was nice because I did well at university, so that was comforting. And then I went off after that, of course I was desperate for money after I'd finished studying in America, so I went back to the UK got a job in Edinburgh teaching occupational therapy at the school at Queen Margaret College. And actually, to be honest, no, it wasn't Queen Margaret College. We were still on the health service, of course, at that point. So the Ashley Ainsley Hospital in Edinburgh was where we were located. But we moved in about 2-3 years after I was there to Queen Margaret College. And at that point, I went on and did masters and moved from there. But my master's was in education. There was no possibility of doing postgraduate work in occupational therapy in those days. So it was all in education.
Yeah.
It suited me fine, actually. That was quite good. I enjoyed it. Yeah.
So then I assume after your time in Edinburgh, you then came back to New Zealand?
Yes, I was there for quite a long time. About 10 years in Edinburgh, I suppose. I taught there. So we saw quite a few changes. And as I was leaving Edinburgh, they were just moving into a degree program. Edinburgh was one of the first ones to get it. So we pushed for that, and we were moving into that just as I was leaving. So I didn't see the completion of the degree program, but I saw quite a lot of the background work in it. Yeah. And the other thing that happened was computers became a reality too. Up to that point, I did my master's on a typewriter, for goodness sake.
Yeah.
So that was a different experience.
Yeah.
And then computing came in, and Queen Margaret College was one of the first places to get computers. They were given to us by the BBC, I believe, and so that was kind of fun. I enjoyed learning, but it was an odd sort of computing thing. What you learned about computers, you learned how to program them. That was the training. The training was in programming computers. Enough to put anybody off, really. Yeah. But however, things have moved.
So when you came back to New Zealand, where did you come back to?
I came back to CIT. Yeah. At the time, Katie Austin was the head of school at the time, and I had known her quite well because I had worked in Invercargill with her previously. So, and she was quite keen to have me there, which was nice. So I worked in the fieldwork program. So I was what they call a fieldwork tutor. So I was responsible for about 8 students or something in the Wellington region. So that was a nice job. We were just working with students constantly in clinical practice.
Yeah.
So that was good. Yeah.
When did you end up in Dunedin then at the Polytechnic?
That was 1990, but that's when they closed down the occupational therapy school at CIT.
Yes.
They had this evaluation. I have no idea on what grounds they did it. I think it's political, but who would know? So they closed it down and allocated 2 other locations for the occupational therapy schools. Became 2 schools in. So Otago was one of them and Auckland was the other. So that's at that point I could have chosen to go either way, but I chose to come down to Otago. It's where I'm from anyway, but my parents were still around at that time too. So it was a good move to come back, really. Yeah.
And we started our conversation looking at occupational therapy back 50 years or more, and how there wasn't the evidence that has accumulated now. So I'm just wondering what your thoughts are about how health professionals maintain the need for that sound evidence-based practice. And the question for me is looking at other professions and looking at OT and asking the question, does occupational therapy have good evidence-based practice?
Well, thank you for the question. I could talk quite a bit on this. Anyway, the answer to that is yes, but we don't always recognize it.
No.
I think we often feel hampered by the fact that we can't predict our outcomes. We don't know in advance what we might do with a client, what's going to work, those sorts of things, because it is a collaboration with the client, makes us effective as a profession. So, and one of the things I did notice when I did a study here in New Zealand just a few years ago, looking at occupational therapists' view of evidence-based practice, and that confirmed my every thought, really, that what happened was people it was like every time you had a conversation with somebody, it was a different conversation. So therapists were really passionate about evidence, but every therapist seemed to have a particular view. It was fascinating, and it depended probably in part on who that therapist was, and their own values and things that really mattered. It probably depended also on the kind of experiences they'd had, the length of experiences they'd had in practice and so forth, and the context, the work context that they worked in. So, and it seemed at the end of the day, what we were committed to was evidence-based practice, really committed to that, but not necessarily to the kind of, at the time, what seemed to be important, which was a critical analysis of the research itself.
Yeah.
So people were keen to read like potted versions of things, the easy read material that really gave them a heads up about what was important in the literature. So that whole struggle with, and it was difficult for the profession to come to terms with trying to read and understand research when most of the professionals had never really had that experience of being researchers. And so it is quite difficult for people to actually take on, critique research. I mean, how else can you do it really, apart from on the basis of what you understand your client group to be and how well that is matched to the research study that you're using. So there were lots of views of that kind of thing about what was really important for people. So, and it did vary tremendously, which is probably still how it is in many ways. Yeah.
And I suppose the pure nature of occupational therapy practice lends itself more to a qualitative approach to research than the sort of quantitative, scientific-based, blind trial around things, which seem to have more currency today, and therefore attracts maybe more attention and funding rather than the quality. I'm generalizing, of course, but rather than the qualitative research. What's your thoughts about that?
Yeah. Yes, I mean, that's changing. That is changing, and qualitative research is more acceptable now. But there was a time certainly when it wasn't. It's interesting. We've had so many developments in the profession when you look at it, and I do remember a long time ago writing for the British Journal of Occupational Therapy. It was when I finished my PhD, I think, yes, and my research had been qualitative, and somebody clearly didn't. So one of the reviewers clearly didn't understand qualitative research, so I had to go back to the editor and say, look, this is how it is. So there's been a lot of changes over time, and without a doubt, occupational therapists certainly go for qualitative research and a lot of what they do. That's not to say quantitative isn't helpful, but it does depend on the practice area that you're in. So, and I think too, I mean, the other thing that we need to pay attention to is who we are as health professionals, that we are occupational therapists. We do come from a particular philosophical stance, and that impacts on that kind of reasoning and the things that we think about. So having a good handle on that total picture of there's research out there, what kind is it, how we pay attention to it, but what else matters. And just recently we've been doing a study down here where we've looked at exactly that kind of thing. What is it that people value in terms of evidence-based practice? What is it we should be teaching in our curriculum? And what is it the clinicians value and students and so forth? So, and we have published one publication so far, but what we found out was there were 5 forms of evidence that were important to pay attention to. So it wasn't just the research evidence was certainly part of it, and the theoretical underpinnings and so forth are definitely part of it. But there was also other aspects like the context that we were working in, because different contexts have different expectations. And there's no point just plucking something out of a research study where the context might vary considerably to what you have. So you have to understand that. And then looking at that particular client, because our clients have different understandings of what's important, and you really have to sort of tune into that to know what might work for that particular person and their particular circumstances. And then the other thing that's really important to pay attention to is expertise. So expertise doesn't always come in the written form of research studies. So some of that comes in from people we know. So it's like for students, they always value the expertise of their supervisors, of course, because they're pretty dependent on them for what to do in this environment. So what works with these sorts of clients and so forth. But looking at the broader picture of expertise, there's a lot of expertise. It could be other team members that you're working with. It might be internationally, people known for that particular topic or working with particular clients. So you could quickly look up their work just to have a look, or look at blogs and things like that. So there's a range of ways you can get expertise. But the other component in all of this is you, because you're going to make the decision. So you bring knowledge with you and understandings with you. And it's really important that you pay attention to that as well, and understand that you have that knowledge and you have values and so forth, and your knowledge might not be complete. So the understanding that what you do now, while it might have worked, you need to think about that and understand that it may not work for everybody, and what are the factors that impacted on the success of the particular one, or perhaps if it didn't go quite so well, what were those things? So that critical view of your own practice is really important. So I just think evidence is not one thing, it's a combination of things. And even when you go right back to the early days in evidence-based practice, where we had Sackett and his colleagues were highly influential, then what they were advocating was, of course, the research and that theoretical component. But not only that, but what was interesting at the beginning was people kind of ignored the rest of it. There was a huge push for research and validating all that kind of thing, and systematic reviews and things like that became really important. But we didn't really have put so much value on the other two things that they talked about at the time, which was the therapist or the clinician themselves, who they were and what they brought to it, and also the client, what they brought to it as well. So already at the beginning there were those three types of thinking around what evidence-based practice was about, but we didn't always pay a lot of attention to all that. So, but it's doing the rounds again. We're coming back to thinking more broadly now.
It sounds like practitioners of today and tomorrow need to be aware of that background of evidence-based practice, where it comes from, being able to critique it, understanding the value that they bring as the therapeutic use of self to the discipline and practice. Are you heartened? I think they also have to be agile to respond to these things. So when we put those things up there, which may describe a practitioner or a profession, are you heartened by what you see in the students that you come into contact with, that the profession is in good heart to measure up to those things you've mentioned, and will be able to practice in the future from a good position?
I think it's various, really. I think there are some things that do reassure me that we are in good heart as a profession. There are some things I feel very unassured, and that is when people they operate basically on the basis of what they know works, rather than look more critically or expose themselves to critique. And it might depend on the environments that they work in, whether or not that happens as a matter of course. And I think that's problematic. And sometimes I see, like, the students, while they're here with us, of course they do critique and things like that, but I'm not so sure. I think they lose the ability to do this quite quickly out in practice. And it's one of the things, there's been a couple of studies about that, where they do say that, in fact, people do lose the ability to be critical and to look at evidence and to read the literature and those kind of things after about 5 years. And it's because, I think it's because in the early days of being a therapist, what they're wanting to do is simply do the practice. And you learn through the practice, and of course you do, and you have to have that in your life. So I suspect they're not seeing quality evidence-based practice in all places. It's, you know, it's out there and it does exist, and it's lovely when you hear the clinicians talking about that and the students reflecting it, those kind of things. But there are some places where clinicians don't value it, and they're not supporting the students or the new graduates in the way that maybe is most appropriate. And sometimes I think, you know, why is it that we're not coming back into postgraduate education? Because I think that is really critical. Once you've got out there and you've done your basics and you're comfortable with your practice, then you should be on to stage number 2, which is looking much more critically. And I'd like to see people doing postgraduate education. I think that's the way to go, really. It's not until you really look critically at the stuff that you're doing that you start to really get the heart of this kind of more research-orientated research. Not that I say it's everything.
I think that's an important observation, actually. Some people would say that occupational therapy is a practice-based profession. You do the job and you can do that job for 30, 40, 50 years. But having practitioners who are able to self-reflect and be self-critical and respond to changes within the health and social care system, those are the types of practitioners we want. And that is, needs to be supported, as you say, with postgraduate programs that support them to actually, change their practice, do different things, think about things differently.
So making that, I don't know how you make it more accessible. And I know people have problems getting money to go to conferences, even do workshops, and then they're not well supported to put things into practice once they've been to workshops and things like that too. So, there's quite a few structural sort of things.
I think there is. I think you're right. It's easier, I guess, for maybe a general surgeon or a physician to get continuing education money because they've got the college structures and the requirement for them to maintain their specialist practice. It's not the same for other professions.
No, it can be difficult. You're competing with other people in the system, and you have to be pretty persistent. But some therapists note that, well, if you don't ask, you don't get. So you might have to be a bit pushy to get some funding and so forth to support you. So and it's not as if we're paid a lot of money, so that it's not as if we have lots of money to spend on education and people have other priorities. But I do think it's one thing that we need to sort of look at in terms of our profession, because unless we can stand up and be accountable for what we do confidently, which is often encouraged through some sort of postgraduate work.
Thank you. As we come to the end of our conversation, Linda, I've asked you again to look back over your career, particularly in education. And when you do that, is there one message that you'd like to give to people that are coming after you? What message would that be?
Well, I think just sort of what we've been talking about, really. I would say something like gain confidence in your thinking skills and keep on learning. I mean, at the end of the day, without the constant learning, you're not going to keep on contributing to the profession in a positive way. So just doing what you normally do is not enough, in my opinion. I think there's always new things happening and new things going on in the world of occupational therapy. So understanding that and working within that framework, I think is you just have to do it.
So you're retiring, and here's an occupational therapy question. So what does a retired associate professor who's had over 113 research outputs, I counted them.
Really? You've made my day.
And the first OT to be given a PhD first occupational therapist given, awarded a PhD, and you're retiring. How are you going to maintain your occupation in retirement, Linda?
I think you might have to ask me that in another year. At the moment, I've got all sorts of plans, but whether they happen or not is another question. I mean, they vary from playing golf and having coffee, the classic really, to writing a book and maybe doing this and that. So, you know, I have some research things I would like to finish off. So, you know, whether it happens or not, I don't know really.
Yeah.
I'll see. I'm not into this retirement quite yet.
Oh, interesting stage in life, I suppose. And, you know, how one maintains occupations within that sort of, you know, retired age is an interesting area. Well, Linda, thank you for taking the time to talk to us, and I wish you all the best for your retirement. And I guess a thank you too, if I can speak on behalf of the profession, to say thank you for the commitment and time you've put into occupational therapy, into the academic world of OT. And I wish you all the best in your retirement, and best wishes.
Thank you. Thank you so much. It's been a pleasure really, and I love the world of education. I'd have to say that the whole thing about teaching and learning and so forth, I've really enjoyed that, and it's been a privilege to be able to do it for so long really. So yeah, thank you.
Thank you, Linda.